اتفضل يا محمد، ومعاك تامر. اتفضل يا محمد.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. طبعا بنرحب بحضراتكم جميعا، ويعني بشكر جدا طبعا بروفيسور اشرف رضا على الكونتينيوس ميديكال اديوكيشن اللي بيعملها، وخصوصا في مجال الريسك فاكتورز ومجال الليبيدولوجي والاثيروسكليروزس. وهنبتدي النهارده بيزيكلي يعني الاسينشالز اوف كلينيكال ليبيدولوجي. يعني بشكر الدكتور اشرف، لسه كنا بنقول قبل اللايف ان احنا هنبتدي موضوع الديسلايبيديميا فروم ذا بيزك باك جراوند اند بيزك بوينت اوف فيو، وبالتالي نبقى فاهمين الراشونال ورا النيو ستراتيجيز اند نيو دراجز. فيعني بشكر حضرتك جدا على الكونتينيوس ويفز يا دكتور اشرف اللي حضرتك بتعملها. It is يعني my honor and a great pleasure to be a part of this event. It is my honor and great pleasure to co-chair this meeting at this session with my dear colleagues and Professor Tamer Mustafa and Professor Muhammad Salim. يعني it is my honor to present my dear Professor Ashraf Rida in the first lecture, lipid particles and metabolic crosstalks. Professor Ashraf, اتفضل حضرتك.
Thank you, Muhammad. Thank you, all my colleagues, and welcome to all the participants. I hope you will enjoy this course, and this course is actually in 6 parts, 3 weeks apart. Each part will be in 2 presentations and discussion. I think it is important to understand all aspects of dyslipidemia, to be able, as Professor Muhammad Al-Nu'mani said, to understand why you are managing these problems and how drugs are working, and what is the meaning of different lipid particles, how they are doing in our body. Let me share my screen here. And of course, I would like to thank Novartis for supporting this educational activity. And actually, this is CME activity with non-restricted support from Novartis. Of course, when we start any lipidology course, I think it is important first to understand what are the lipid particles in our bodies and how they are working, what they are doing, how they can crosstalk with each other to finally either lead to atherosclerosis or either lead to the function they are present to do, formation of hormones, formation of cell membranes, and so and so. If we are talking about lipid metabolism is a collection of many procedures. It is the synthesis or degradation of fats inside the cells. It is also the storage and the breakdown of fat for usage for energy. It is important for the synthesis of structure and functional lipid like cell membrane, like hormones. Lipid is present in our body in the form of triglycerides, cholesterol, membrane lipids, and fatty acids. And all these are present in a particles called lipoprotein particles, which is present in our body. They are hydrophobic and carried in the blood. Okay. This is example of the main particles, which is LDL, or low density lipoproteins. I want to stress here now that there is a big difference between LDL and LDLC. What is the difference? LDL is a particle itself, is a low density lipoprotein. LDLC, or LDL cholesterol, is the cholesterol content of all the LDL particles in our body. So when we are measuring LDL cholesterol, we are measuring actually the cholesterol content of the LDL, all the LDL particles in our body. We are not measuring the LDL particles itself. LDL particles is something new, and it is called LDLP. So LDL actually is not. These questions was one of the questions of Yava at Ramadan daily quizzes the year ago. What is LDL? It is a cholesterol. It is a cholesterol ester, or it is a cholesterol transporter. Actually, LDL is a particle that transport cholesterol and others, like cholesterol ester, triglycerides, and others in the blood. So it is actually LDL is not a cholesterol. It is not a cholesterol ester. It is a cholesterol transporter that helps to transport cholesterol in the blood and in our bodies. This is simplifying the type of particles in our body that carry cholesterol ester and triglycerides. They are all showed some structure similarities. However, on the left-hand side is the atherogenic particles, and on the right-hand side is the protective particles, which, as you know, is HDL. So all the cholesterol content of these atherogenic particles are atherogenic and called non-HDL cholesterol. However, the cholesterol content in the HDL is different, and this is called the HDL cholesterol. So it is very important to know that LDL is not the only atherogenic particle in our bodies. All the metabolic sequelae of VLDL, intermediate density lipoprotein IDL, LDL, chylomicron and its remnant, and even the lipoprotein Ldl, all these are atherogenic particles. So we have to look at the picture in whole to know that we are not only treating LDL cholesterol, but we should be concerned with the other cholesterol in the other LDL particles in our body. So when we are measuring the total cholesterol, what is the total cholesterol? Total cholesterol means the cholesterol present in all these particles, whether HDL, LDL, chylomicron, VLDL. So it does not mean a lot. Of course, when the higher the total cholesterol, the higher the incidence of atherosclerosis. However, maybe most of this total cholesterol is HDL, for example, and here it will not be atherogenic. When we are measuring HDL cholesterol, that means that we are measuring the cholesterol content of the HDL. LDL cholesterol, we are measuring the cholesterol content of LDL. So it is very important to measure the non-HDL cholesterol. And what is the meaning of this important parameter? It is the cholesterol content of all the atherogenic particles in our body other than the HDL. So it is very important to determine the atherogenicity of our lipid profile. Another important constituent of this lipoprotein is something called apolipoproteins. Apolipoproteins, this is represented here, by, for example, by this red line. We have many types of apoproteins in this on the surface of these lipid particles, and apoprotein is very important because it determines the function of the lipoproteins. It determines the receptor that will deal with these lipoproteins, and it is very important to know that the ApoB lipoprotein is present in all the atherogenic particles, all the lipoprotein particles, other than the HDL, have ApoB on their surface. So LDL have ApoB, chylomicron have ApoB, VLDL, and all the intermediate dense lipoprotein. HDL carry ApoA1, which is different, and determine the function of the HDL cholesterol. So apoproteins is very important in our assessment of the atherogenicity of the lipid particles in our body. For example, the higher the ApoB particles, that means the more atherogenic is our lipid profile. This is the ApoB proteins, and this is the particles containing or carrying on the surface the ApoB lipoprotein. All the atherogenic particles, like VLDL, intermediate density or IDL, LDL, lipoprotein Ldl, and the chylomicron, all carried ApoB. ApoB 100 on all of them, except the chylomicron ApoB48. So it is very important to assess the ApoB particles. The higher the ApoB particles, the smaller the particle size, the more the atherogenic is the lipid profile. And this is to show you how this apoprotein is very important in determining the functions and the receptors interaction of the lipoprotein particle. For example, if the particle is atherogenic and it has ApoB proteins in the surface, it is recognized through this ApoB by the liver receptors. And the fate of these particles containing ApoB, the fate we hope to be the dominant pictures in our metabolism, is to be taken by the liver receptors, internalized, and then finally leading to degradation of this LDL or other atherogenic particles to amino acids, cholesterol esters, and fatty acids. Lipoprotein, Dr. Ahmed Shawqi will discuss with you in detail the lipoprotein little a. It is one other atherogenic particles. I will in 2 slides show you that the basic structure is essentially an LDL-like particles containing the ApoB lipoproteins, the phospholipid, the core of cholesterol ester and triglycerides, but it characterized by the presence of this apoprotein little a. And this apoprotein little a shows structure similarity with plasminogen. And this is why these particles is not only atherogenic like the LDL, but it also atherothrombotic due to its structure similarity with plasminogen. I will not extensively discuss the pathogenetic mechanism of lipoprotein little a, but it has pro-inflammatory, it has pro-thrombotic, it has pro-atherogenic effect due to its unique structure similarity. Of course, the high lipoprotein little a is a rare congenital problems leading to myocardial infarction, whether atherogenic or thrombotic, leading to stroke, leading to aortic stenosis. HDL. HDL is the protective lipoprotein in our body. And as you see, it is the same picture, phospholipid membrane, lipid core of cholesterol ester, and maybe some triglyceride. But the main particles of HDL is the phospholipid, the free cholesterol, and if important determining the function is the apolipoprotein A1. This is very important to so that this apolipoprotein little A1, apolipoprotein A1 tenses in the liver with some free cholesterol and some phospholipid begin the first step in the structure of HDL in our body. HDL is very important in our body and how it exerts its protective mechanism. This is exerted through what is called reverse cholesterol transport. This is on the bottom of the slide is the hepatocyte, and the top of the slide is the peripheral tissue and the macrophage. And of course, the usual cholesterol transport pathway is starting from the liver, formation of the VLDL, then LDL going to the peripherally to goes atherosclerosis to be taken the macrophage. HDL has another pathway. It is reverse cholesterol transport pathway, starting from the peripherally to collecting some free cholesterol and the ApoA1 and some phospholipid to start what is called nascent HDL or disk type HDL. HDL is a dynamic particles. It is unstable particles. It is transformed in our body to many forms. One of the forms is the HDL3, which is by addition of more free cholesterol become and stratification of this cholesterol by L-cat to cholesterol ester, it become rounded particles, not disk particles. Then by additions of more cholesterol ester and triglycerides, this is the mature HDL cholesterol, which is finally taken by scavenger receptor B1 by the liver to get rid of the cholesterol. So this is what called reverse cholesterol transport from the periphery to the liver to get rid of the atherogenic cholesterol. This is called LCAT centric model of reverse, because it depends on this LCAT enzyme, which main function is esterification of the cholesterol in the core, leading to cholesterol ester formation. And actually, discovery of HDL took decades to start to realize its link between HDL and atherosclerotic cardiovascular. It was discovered in 1930, and only take many years, in 1977, when the result of Framingham study confirmed that the higher the HDL cholesterol, the less or the more protection against atherosclerotic cardiovascular disease. And actually since that, many attempts to discover drugs that increasing HDL cholesterol in our body, but actually many of them failed. And why it failed? It failed not because HDL is not protective, but it failed because, as I showed you, HDL is very dynamic. It is unstable particles. We have many forms: disk type, premature, and mature, and we don't know whether these drugs that increasing HDL cholesterol, it may increase the mature type of HDL cholesterol, which is not capable of carrying additional cholesterol. Maybe this is one of the explanations. There is many explanations to the failure of this attempt still now. However, there is correlation, definite proved correlation between the level of HDL cholesterol in your body and the protection against atherosclerosis. This is a schematic presentations of this crosstalk of the different particles in our body. Of course, as you know, the liver is the main source of formation of lipoprotein atherogenic particle, which is VLDL. VLDL is a triglyceride-rich lipoprotein particles. Okay, these triglyceride-rich lipoprotein particles undergo lipolysis, leading to remnant triglyceride-rich particles, which is intermediate density lipoproteins. Further lipolysis lead to formation of the LDL or low density lipoprotein. This pathway is atherogenic, and all these particles is atherogenic. Even the remnant particles, which is become very important, and we discovered in recent years the importance of assessing not only LDL cholesterol, but assessing the remnant particles or triglyceride-rich particles. And these triglyceride-rich particles, how can you know that you have high remnant triglyceride-rich particle? This thing by doing non-fasting triglyceride levels. If your non-fasting triglyceride level is high, if the postprandial triglyceride is high, that means that you have higher number of remnant triglyceride-rich lipoprotein particles. The other source of atherogenic particles is the small intestine from the food. It's forming the chylomicron, which is nearly similar to VLDL, rich in triglyceride, and in the same way undergo lipolysis and leading to remnant also particles. These remnant particles, triglyceride-rich lipoproteins, and it is atherogenic. HDL, as I explained to you, starting by formation of this disk type or nascent HDL, some phospholipid, some free cholesterol, and the ApoA1, and undergo maturations, undergo metabolism, and carrying the additional the excess cholesterol in our body. All the time, there is crosstalk between this HDL and these atherogenic particles on the either sides of the slides. This crosstalk is activated by a protein called CETP, cholesterol ester transfer protein, and by its name, cholesterol ester transfer. It transfers cholesterol ester from the HDL to this atherogenic particle in exchange for this additional or high content of triglyceride. And by the end of the day, this crosstalk, if you have high triglyceride content, will lead to the particles become smaller and denser and more atherogenic. So it is very important to understand the interaction between HDL cholesterol and all the atherogenic particles and the effect of high triglyceride in our body on this crosstalk. So we have to know that all the ApoB containing lipoproteins are potentially atherogenic, whether they are very low density, whether they are triglyceride-rich lipoproteins, LDL cholesterol. But it is very important to know that LDL particles may be more important than assessing LDL cholesterol, because you may have high LDL cholesterol or 100 milligram per deciliter LDL cholesterol, but low LDL particle numbers. And this is less atherogenic than if you have the reverse. If you have even small cholesterol content of the LDL, but the particle number is high. And why the particle number may be high, despite that the LDL cholesterol in the same in 2%? Many factors that leading to increase the particle number. One of them is the high triglyceride in our body. And the high triglyceride, as I explained in the previous slide, lead to previous crosstalk between the HDL and these atherogenic particles, and leading to increase the number of LDL particles. So it is very important to assess the triglyceride-rich lipoproteins, all in all, not only the LDL cholesterol. And that's why measuring ApoB protein is very important, because the higher the ApoB proteins means that you have higher numbers of the particles, LDL particles, and smaller particle in your blood. And this is a diagram to explain that two persons may have the same LDL cholesterol content, 100 milligram per deciliter here and 100 milligram deciliter here. But this 100 milligram is distributed in many small particles, in contrary to this one, who are the particle size. This is more atherogenic. The one with the small particle are more. How we know this? If you measure ApoB, as you know, each LDL cholesterol carry one ApoB protein. So here we have 5, for example, ApoB proteins. This is, of course, to explain the situation. And this is on the reverse, have more ApoB proteins. So the higher the ApoB proteins means you have LDLP particle number higher. The higher the particle number, and the smaller the particle size, and the more the heterogeneity of your LDL in your body. So as I told you, in the last few years, we are, all the scientists be very interested in what they call triglyceride-rich remnant lipoproteins. These are lipoproteins carrying higher content of triglycerides. And this situation is happening when your triglyceride is high. That's why the importance of the high triglyceride in our body, because that means that you have a higher triglyceride remnant lipoprotein. It is atherogenic. It contains also ApoB. It may be the results of the lipolysis of VLDL or chylomicron, leading to intermediate density and many of these triglyceride-rich lipoprotein. And as I told you, how to assess? By measuring the postprandial triglyceride in the non-fasting state. And actually this triglyceride-rich lipoprotein is affected by the level of triglyceride in our body. In these slides, it shows the effect of the higher the triglyceride level from the left to the right on each on the different lipoprotein particles. How can triglyceride affect the HDL? How can triglyceride affect the LDL? And how it can affect this remnant atherogenic particle? If the higher the triglyceride level, the lower your HDL. This is number one. Number two, the higher the triglyceride level has no implication on the LDL cholesterol level. LDL is the same not affected really by the higher triglyceride, but the higher triglyceride affects the particle size of the LDL cholesterol, not the LDL itself. However, the striking effect of the higher triglyceride level is the increase in the remnant particles, which are very atherogenic. So actually, when you look at the guidelines, if you want to do comprehensive lipid management, you should not only look at the LDL cholesterol. You should look at all the atherogenic lipoproteins. You should look at the cholesterol content of these atherogenic lipoprotein. That's why the guidelines telling you that non-HDL cholesterol is very important, and we have we have target of therapy for non-HDL cholesterol, which is less than 85 milligram or 100 or 130. Very high risk 85, high risk 100, moderate risk 130. This is the non-HDL cholesterol, and as I told you, this is a measure of the cholesterol content of all the atherogenic particles. Another important parameter in the guideline is the ApoB. ApoB, as I told you, the higher the ApoB, the more the particle numbers and the less density is the particle size. So we have also target less than 65, 80, and 100 according to the risk, very high. Also, the highlight of the importance of the triglyceride, there is desirable level of triglyceride which is less than 150, because we know now how high triglyceride level can affect these lipoprotein particles in our body. They can increase the triglyceride-rich lipoproteins. They can affect the particle size by activating the crosstalk between HDL and the other particles through activation of the CETP and making the particle size smaller, making the triglyceride-rich lipoprotein remnants higher, leading to more atherogenicity. And thank you for your attention, and I will leave the mic to my colleague for if there is discussion of this presentation.
Many thanks, Professor Ashraf. Very elegant presentation as usual. Actually, you have simplified this tough target as usual, Professor Ashraf. Actually, I have a comment and a question for you. The comment that we have a very valid lipid parameters like ApoB, ApoA ratio, or total cholesterol over HDL cholesterol, and the non-HDL cholesterol. And it is well known theoretically that the non-HDL cholesterol have more valid and real-life prognostication than the LDL, because it includes the dangerous effect of non-LDL parameters like lipoprotein a, very low density lipoproteins, and remnant of triglycerides. My question for you, what do you think about the gap, about the importance of these lipid parameters and the lack of its use and the validation in the guidelines? Still, we have the tough targets by LDL, although non-HDL cholesterol is very important. Apolipoprotein B over apolipoprotein B A is another important ratio. What's your reasoning and explanation?
Very important questions. Let me first of all welcome Professor Hazem Khamis, Professor Hani Ragi. They joined us.
Professor Hani, ازي حضرتك؟
دكتور هاني مساء الفل.
Actually, this is very important question, Dr. Muhammad, and this explains what we are calling the residual risk. Why we are giving treatment for cholesterol and still we have a lot of cases of acute coronary syndrome despite statin therapy, because we are not looking at this after controlling the LDL cholesterol. You should looking at this non-HDL cholesterol. You should looking at ApoB, and despite the guidelines telling us that, the guidelines is not only the LDL. You have the LDL, non-HDL, ApoB, and triglycerides. So you have comprehensive management of lipid is very important if you wanted to decrease the residual risk and to achieve the maximum protection regarding the lipid management and atherosclerosis.
Thank you, Professor Ashraf. Professor
أشرف بنشكر حضرتك جدا على المحاضرة الرائعة دي. أنا عايز أسأل سؤال بالنسبة للريمننس أوف triglycerides rich lipoproteins. هو الحقيقة طبعا واضح إن دي حاجة يعني إحنا الترايجليسرايدز القياس بتاعنا ليها is a surrogate marker للبارتكلز دي، بس مش هي. in actual practice هل في طريقه لقياس الريمننس of triglycerides rich lipoproteins وايه السيجنيفيكانس بتاعها؟ هي اثروجينيك، اوكي. هل في كل الناس ولا only in diabetic and metabolic syndrome؟
Okay, another important question, Dr. Salim. So the triglyceride rich remnant lipoprotein. It is an atherogenic lipoprotein, as LDL exactly. In addition, it can cause more atherosclerosis. Why? Because the high content of triglyceride leading not only to the usual cascade of atherosclerosis, it is like the LDL, it can penetrate the endothelium, engulfed by macrophage, leading to foam cells and atherogenicity. But in addition to that, the high content of the triglycerides leading to high free elaborating more fatty acids, free fatty acids, and this is more inflammatory effect. So it have more inflammation to the subendothelial part when it penetrates. So how to assess? First of all, non-fasting triglyceride. The higher the non-fasting or even the fasting triglyceride, that means that our triglyceride-rich lipoprotein particles are many. Second of all, because it is like structurally like LDL, it contains ApoB. So the higher the ApoB, also it is an indirect assessment of these triglyceride-rich lipoproteins. So you can assess by different way. However, there is no measurement. Actually, the Copenhagen population study put some numbers for this triglyceride-rich lipoprotein. Less than 20 is low risk, and more than 50 is high risk. So it can be measured actually, but in our lab we have not this measurement yet, but it is measured actually, and there is numbers for the low risk, moderate risk, and high risk according to the. But we can assess indirectly high triglyceride, high ApoB. That means that you have, especially the non-fasting, the postprandial triglyceride. Why? Because after meat, in the first 2 or 3 hours, the high triglyceride content means that we have higher number of these triglyceride-rich lipoproteins. But few hours later, this triglyceride is metabolized and the lipid profile is stabilized, and you will not find the same as postprandial hypertriglyceridemia.
راشد بيه.
دكتور حازم.
طبعا مساء الخيرات على حضراتكم. يعني انا بس مش هطول. انا اسعد حاجه من اسعد الحاجات اللي في حياتي ان انا ارتبطت بالقيافه دي اللي سيادتك ترص. تاني حاجه اول مره ارتبط بالديسليبيديميا دي، يعني من يوم ما بقيت اسمع حضرتك وانت بتتكلم عنها كنت بحس ان السبجكت ده، يعني ايه السبجكت البايخ ده، يعني فيري تاف ساينس. يعني في الاخر يعني انا دكتور اشرف عايز نكتب روزا ستاتين 40، يعني خلاص ما نكتب 40 ونخلص. يعني كنتش الواحد يتخيل قوي كميه هذا العلم لحد بقيت اسمعه وبقيت اقول محاضرات فيه. كان اول ما حد يحاول يديني محاضره في الديسليبيديميا اقول له يا عم انا ابعدني، يعني الديسليبيديميا ايه يا عم، مش وجع دماغ. دي المقدمه اللي نفسي يعني جزاكم الله خيرا على التغيير اللي حصل لنا بيرسونال في هذا البرانش. الجزء اللي بعد كده الصوره اللي وراك دي انا محتاج كوبي منها، يعني الصوره مش عاديه. الصوره مش عاديه.
دي من الميتنج اللي فات يا دكتور حازم، خلي بالك.
سؤالي بقى، وده from the clinical practice, there is a very big link between the diabetes, uncontrolled diabetes and the hypertriglyceridemia. يعني ان انا ساعات ببعت العيانين دول اول ما الاقي الترايجليسيريديميا دي انك انت يو نيد تو كنترول الدايابيتس. ايه اللينك ده؟ هل في حاجه في الميكانيزم، حاجه في الباثوفيسيولوجي اوف دايابيتس اند ديسليبيديميا تخلي وانس الانكنترولد دايابيتس الترايجليسيرايد في السماء، يعني تلاقي الكوليسترول والال دي قليل، لكن دائما الترايجليسيرايد في الانكنترولد دايابيتس از فيري هاي. وشكرا وجزاكم الله خير.
Thank you, Awan, for nice words. Hazem, actually, you are great scientists and you are knowledgeable man, and I am. It's my honor to have you with me, طبعا, in the board of IAVA. Second of all, of course, the main link is the fatty acids. Glucose metabolism, high fatty acids, high triglyceride level. This is the main link that work, and the high triglyceride level will starting crosstalk between HDL and LDL and so and giving the sequence of atherosclerosis. But the fatty acids and fatty acid oxidations and glucose oxidation leading to more fatty acid in our body, more triglyceride. Because what is triglycerides? It is some fatty acids with some other particles. I hope I could answer the question.
أشرف حضرتك تسمح لي بس أضيف جزء هنا. الحقيقة يعني ملحوظة الدكتور حازم يعني very valuable. Actually في العيانين الدايابيتك بيبقى الكريبس سايكل is impaired. والكريبس سايكل يعني محتاجة الأكسجين ومحتاجة البروبر انسولين and بروبر جلوكوز ميتابوليزم. Actually في الناس الدايابيتك بتبقى الكريبس سايكل is impaired. فبالتالي يعني الباس واي بتاع الاكسف اسيتيت والاسيتايل كو زي ما حضرتك قلت الفاتي اسيدز بتبقى ديفييتد من الانرجي برودكشن انتو ترايجليسرايد اند كوليسترول سينسز. فبالتالي كل السبستريت اللي كان المفروض يستخدم في الانرجي برودكشن از شيفتد تو كوليسترول اند ترايجليسرايد سينسز. وده يمكن الراشونال ان كل العيانين زي ما الدكتور حازم اللي قال ان كل الناس اللي هم ان كنترول دايابيتس بتلاقي حضرتك فيهم كواليتيتيف تشينج في ال دي ال بيبقوا سمول دنسر اشورجينيك بالرغم ان هو ما بقاش عالي قوي في التحليل، بينما الترايجليسرايدز بتبقى فيري هاي. دي يعني حبيت اضيف بس
دي وبشكر بروفيسور محمد.
دكتور اشرف بعد اذن حضرتك الاي او بي في اخر 2 جايد لاينز عليه كلام كتير تمام، انما البراكتيك وايز هو اوي. حتى كان الناس بتوع احد المعامل الشهيره يعني طلبوا ان هو يبقى في محاضره في محاضرات الليبيدز امتى نطلب الاي او بي. فحضرتك الريكومنديشن بتاعت حضرتك ايه؟ احنا اتكلمنا عليه جوه الساينتفك ليه رول كبير بيأثر على افكتس كتير قوي، بس براكتيكال وايز ما بتطلبوش. When do you recommend to go for analysis of the ApoB?
Actually, the basic lab needed is the lipid profile, total cholesterol, LDL, HDL, and triglycerides. Then, after controlling the LDL cholesterol, you can look at the other parameters. Non-HDL cholesterol, which is non-HDL cholesterol easy. Total cholesterol minus HDL, you can calculate it from the lipid profile. But you can measure ApoB after controlling the LDL cholesterol because it is one of the main targets of lipid management in the guidelines. So you have to reach the
امتى اقول الجروب دي او البيشنت ده ريكومندد ان انا اعمل له ايبو لايبوبروتين بي؟
I do it routinely after controlling the LDL cholesterol because it is one of the targets. I should look, especially in those with LDL cholesterol level within the goals and having more events, other events. Okay, after this is specific situation, but however, I recommend it as one because it is in the guidelines. You have to measure it after controlling LDL cholesterol, after doing your effort to controlling the LDL cholesterol, because actually you will not have a specific treatment for ApoB. It can help you in increasing the dose of statin therapy to getting the LDL more and more toward the target and to control the lifestyle. It's very important to assess to affect the ApoB, the triglyceride level, the dieting, the exercises, and all and all. Hani, you want to?
الحاجة الثانية احنا واي ككارديولوجيست او كناس في الليبيدولوجي كويسين دلوقتي، ليه مش نبص لعيان الدايابيتيك بانذر فيجن؟ يعني احنا برضو عندنا ال LDL تارجت ومش هنختلف عليه، انما الدايابيتيك بيشنت عايز يتحط ان البارامترز كلها مع بعض من اول السطر. يعني هيتحط من اول السطر والايبو بي من اول السطر، لانه الدايابيتس لوحده ليه تايب اوف ديسليبيديميا خاص بيه. فواي نوت ان احنا ما نكونش الركائز اللي تكون تبدا انك تبص لعين الدايابيتك من اول السطر بالانفستيجنز كلها، يعني تحسب له النون اتش دي ال ودي بالورقه والقلم، نحسب له الايبو ونشوف ليه ما تبقاش دي ريكومنديشن موجوده من عندنا انه عيان الدايابيتك لو سمحت ادي دي فيجن في اكتر من العيان الاسيسكلوز العادي.
We are following the guidelines And the main aim of the diabetic patient, in addition, of course, of controlling hemoglobin A1C, is to getting the LDL cholesterol to the maximum lowering you achieve according to the risk and duration of diabetes and presence of other risk factor and target organ damage and so on and so. But it's very important, as you tell, to look at the triglycerides, look at the non-HDL cholesterol, and look at the ApoB, because this patient is highly atherogenic, liable to acute coronary events. I think last question from Dr. Hani to be in time. Dr. Hani.
Thank you very much. أولا أنا برضو زي دكتور حازم خميس واحد من أحسن الحاجات اللي حصلت لي إن أنا بقيت عضو في اليابا which is something هو قالها وأنا حسيت بيها وهو بيقولها. الجايد لاينز بتتحط وفي ذهن الناس ان كل كلمه بتتغير فيها بتؤدي الى financial consequences عالميه رهيبه نتيجه اضطرار دول كامله وانظمه تامين خياليه في الغرب انها تصرف ادويه للمرضى. وده ناتج عنه ان احنا بنعالجهم في المراحل النهائيه من المرض يا دكتور اشرف بعد ما يكون حصل لهم تصلب الشرايين. انما احنا كلنا عندنا ولاد او يعني كتير منا عندنا ولاد في صغيرين بس ما عندهمش. ومهم جدا ان احنا نعرف ان ولادنا الاكسبوجر بتاع الاثروجينيك بارتكلز.
I want to excuse me, Hani, in English because we have a foreigner with us.
Sorry, I'm really sorry. Yeah. Okay. I just want to say that the lifelong exposure of humans to atherogenic particles, whether they're LDL or you know, lipoproteins or ApoB, actually causes a lot of subclinical atherosclerosis.
Yeah.
And we're not looking at that in the moment. We're just looking at populations with definite atherosclerosis. And one of the reasons that the guidelines are very, very careful about this is that there are huge financial implications to starting treating asymptomatic individuals. But we do know that you know, like I work in smoking cessation, and when we calculate how many cigarettes a person smokes, we don't just look at 20 cigarettes a day now, we talk about pack years, because somebody has smoked for 50 years is different from somebody who has smoked for 1 year. Somebody who's had high LDL for the last 6 years, even if it was moderate elevation, is different from somebody who's gone on a keto diet and has had high LDL for the last 3 months. So it's a very complicated issue, and I think we should look at subclinical atherosclerosis. At this point in time, we obviously have to follow the guidelines, but you know, subclinical atherosclerosis falls within the guidelines because this is atherosclerotic cardiovascular disease, but it's asymptomatic. So we should use aids to lab testing, Professor Ashraf, which you know, you may have deliberately chose not to mention, but I mean, I'm talking about calcium scoring, I'm talking about, you know, looking for plaques and carotids, a lot of other tools that we must use. And my last point is I want to ask you a question. Very recently, some of the lipid gurus are questioning the whole issue of the HDL. They say HDL is not, low HDL is not a cause of atherosclerosis, and they use a lot of proofs. They think it's just a marker. But one of the arguments they use is that when you truly manage to elevate HDL by all sorts of drugs, it doesn't work. So what's your feedback on this? Thank you.
Actually, this is very important observations, and there is many explanations why we are, when we giving CETP inhibitor, for example, or any drugs that can increase the HDL, why there is no reduction of cardiovascular event. And one of the explanations that regarded to our basic course of lipid particles is that HDL is a dynamic particles. Not all HDL cholesterol in our HDL particles in our body are the same. There is disk type, there is type which is like a vehicle which is empty, is able to carry further cholesterol. But there is the mature type, which is full of cholesterol, ester, and triglycerides, and cannot carry additional cholesterol from the periphery to the liver. So we don't know which type is increased by these drugs. So you may, by these drugs, increase the wrong type of HDL. This is one of the explanations. Of course, there is other explanation related to the hypertension, mild increase in blood pressure with these drugs. But this is explanations, not proved actually, but the only conclusion of these studies is increasing HDL by these drugs is not working till now. There is more trials now is going on to try to find other ways of increasing HDL.
The other half of my question, Professor Ashraf, is you're only looking at surrogate markers, which is lab work. I would like us to also look at the target organ damage, which is actual atherosclerosis. So what is your feedback on calcium scoring, or even coronary CT angio for high-risk population? I mean, you will find patients with borderline lipid profiles with events and even with sudden death. So how about looking for atherosclerosis?
As you explained, Hani, a nice observation is what is called recently the cumulative LDL cholesterol effect, like cigarettes. High LDL cholesterol, even moderate elevation, as you explained and said, for long time of periods can lead to atherosclerosis, subclinical atherosclerosis before the event. How we can deal with this problem? This is leading to the concept of the earlier is the better. If you risk stratify a 16 years old young person for coronary risk stratification according to the available risk score, you will find the risk score is very low. You will not give him a statin. However, if this guy have a positive family history of premature atherosclerosis, for example, have mild or moderate elevation of LDL cholesterol, he is liable. That's why there is now genetic risk scoring is another player to start to pick those liable to atherosclerosis after 20 or 30 years to start preventive measures earlier in their lives. So it's very important at this time when you find mild to moderate risk, you can enhance your risk stratification by, for example, calcium score, by measuring ApoB, by doing other tests for subclinical atherosclerosis. I think we can move to the Dr. Tamer to the next presentation. Further, Dr. Tamer.
Our next presentation will be with Professor Ahmed Shawi. He will talk about the lipoprotein A in clinical practice. Dr. Ahmed, let's go.
Thank you so much. It's a pleasure being with you, Professor Ashraf. I love the way you're really challenging us to really open up and really look deep into the lipids and problems. I will always like to understand, and this is what we're going to do today in lipoprotein. Lipoprotein A actually has been really increased all over the few past years, and since its recognition by Berg in 1963, there's a lot of data right now on lipoprotein A. It still is a little bit elusive, and today we're trying to shine a light on what is going on with this particle. What are the major lipoproteins? This is a quote from the guidelines of the ESC in 2019. They are not just the VLDL, LDL, IDL, HDL. No, they also include the lipoprotein A. And lipoprotein A, as you can see from the different comparisons between it and the other lipoproteins, it's very similar in size to the LDL and IDL. Also, the triglyceride content is similar to LDL. The cholesterol esters is similar a little bit to LDL. and its content is mainly apolipoprotein A, and its surface has the apolipoprotein B100, which is very common in LDL, IDL, and VLDL. So it's a similar, what you can call marker to LDL. How does it look? It looks a little bit like the LDL, and Professor Ashraf alluded to this. The core is mainly apolipoprotein B, and apolipoprotein B on the surface. There are so many isoforms of lipoprotein A, and because of the Kringle 4 repetitions, there could be a lot of isoforms, and this is a problem that the surface Kringle 4 repetitions can make the estimation of lipoprotein A actually very difficult. And this is why there could be a huge range, very high lipoprotein A in African races, less in Caucasian or Asians, less in different other minorities. So it's quite a little bit difficult to really assess how we are going to assess the levels of lipoprotein A. Lipoprotein A actually is affected by so many things. Genetically, the main gene of lipoprotein A is on chromosome 6, and there are mutations that can cause differentiation in lipoprotein A levels. Also, non-genetic factors like an acute myocardial infarction, actually renal disease can increase lipoprotein A, and this is why sometimes end-stage renal disease and CKD is a cardiovascular risk factor. Diabetes indirectly also can elevate lipoprotein A, liver diseases, and alcohol. Look at the hormones, thyroxine, and sometimes there were data or trials to use thyroid hormones to reduce actually lipoprotein A. Elevation in pregnancy, reduction with some hormones, most hormones, especially the estrogen-containing hormones. And the drugs or apheresis also can change this, but we're going to discuss this in the management. Let's start with the biggest problem. I said lipoprotein A has so many isoforms. How can we measure it accurately? Actually, I'm just trying to show you how many different techniques that is being used really to assess lipoprotein A. And the problem is there is a variable molar mass because of the polymorphism of lipoprotein or the apolipoprotein A also. And there could be an underestimation, especially those with the small isoforms. Trying to target using monoclonal antibodies to assess the different isoforms is a little bit difficult because of the variable numbers of epitopes. Also, purified lipoprotein A is unstable, and thus sometimes there is a higher degree of self-aggregation, and this might really obscure the accurate laboratory measurements. So it's not so difficult. And there are so many data. The WHO has its data, and there are other international societies having their data. Is it milligram versus over deciliter versus nanomoles over liter? What can we do? Are there different cutoff points according to the risk populations or the ethnic populations or the comorbidities? But definitely, there is a predilection that assessment of the particle concentration may be more accurate than the mass concentration, alluded by Professor Ashraf in his previous presentation, that sometimes you can underestimate the smaller isoforms. So we need a standardized assay that can even assess the amount of atherogenicity in this lipoprotein, and also harmonize this assessment for the clinical studies that are going on or have been planned. This will help establish a better evidence-based guideline for management of patients with lipoprotein A increase. So this is the data. And also, we should have cutoff points according to the gender, to the ethnicity, because we see that the African Americans, especially African descent, have higher lipoprotein A. And also, they should be assessed according to some comorbidities that might affect the different levels of lipoprotein A, like thrombophilia, diabetes, familial hypercholesterolemia, renal disease, and so and so and so. So what is lipoprotein A and the risk of atherosclerosis? How does this hepatocyte manufactured lipoprotein affect us? Well, actually, as Professor Ashraf said, it is an atherogenic lipoprotein. It is also similar to plasminogen, and thus it can reduce fibrinolysis. This is why it's a little bit of prothrombotic. And also it can inhibit the function of tissue factor pathway inhibitor. Not only that, it carries the atherosclerosis causing cholesterol. And this causes inflammation with the oxidized phospholipids, and this leads to smooth muscle cell proliferation and more atherosclerosis. Also, it has relation to vitamin C and wound healing, and it's interacting with the vascular wall and extracellular matrix, which also can contribute in the atherogenic process. Lipid oxidation increased levels of oxidized phospholipids, but also don't forget that this lipoprotein A can also has been attributed as a cofactor in primary hypertension or essential hypertension. Another finding has been seen in some studies that is an initiator of acute plaque rupture in acute coronary syndrome. So it is a problem in so many different diseases. And this sums it all up. It's pro-inflammatory, pro-atherogenic, pro-thrombotic, different mechanisms of action. It's a bad lipoprotein. It's the sister or the brother of LDL cholesterol. So it is not something which is not really required so much. Difficult to measure, difficult to have a definite assay on what are the targets and so, but definitely something to be put into consideration. Why is it important? If you look at the risk-enhancing factors that have been alluded to by the American guidelines or the National Lipid Association guidelines, there's so many. And one of them actually is elevated lipoprotein A, especially above 50 milligrams per deciliter or 125 nanomoles per liter. And this is one of the risk-enhancing factors. So it is important, just like apolipoprotein B, that ApoB, increase, like Professor Ashraf said, it's one of the risk-enhancing factors that should be taken into consideration in certain cases, not every single case. And data from different studies, for example, this is the Copenhagen City Heart study, lipoprotein A, as much as it does increase, definitely it increases the incidence of myocardial infarction, whether males, whether females, whether smokers, whether non-smokers, whether young or old, it does help. And you can see the pattern of increase in lipoprotein A with the increase in the 10-year risk of a myocardial infarction. It does have also a relation to cardiac death and even non-fatal acute coronary syndromes, bypass graft restenosis, and to a lesser extent, I'm not going to say this is a very strong relationship, but it does to ischemic cerebrovascular stroke. And this is seen not only through case control studies, but also prospective studies. So it does increase coronary artery disease. It does increase different entities of the coronary artery disease, the stable, the unstable, and the restenosis, and also the strokes. Even those on statin-treated patients, the MACE does increase in those on statins and controlled for the LDL with an elevated lipoprotein. These subgroups should be taken into consideration at higher risk than the others with a low lipoprotein A level. So what do the guidelines say? Because I know what you're thinking, okay, if this is so important, why don't we measure it in every single patient? It's not so easy. Again, the standardized, what we can say, levels are not so valid in most laboratories. But let's look at the National Lipid Association. Any patient who's an adult with a family history in the first degree relative of premature coronary artery disease, that's a class 2A. Those in the absence of traditional risk factors, also class 2A. Those with an increase in LDL over 190, those who are at very high risk for atherosclerotic cardiovascular disease, especially those that might benefit from a PCSK9 inhibitor therapy, because these medications are probably one of the best medications to lower lipoprotein A. Others, like intermediate or borderline risk, intermediate risk is the most important. And to a lesser level of recommendation, those with less than anticipated LDL cholesterol lowering despite adherence to therapy, those with a family history of elevated lipoprotein A, calcific aortic stenosis and lipoprotein A, as well as low density lipoprotein, have a correlation with that, recurrent or progressive atherosclerotic cardiovascular disease. Also, in the young, especially if there is clinically suspected familial hypercholesterolemia with family history in the first-degree relatives, especially in cases of an unknown cause of an ischemic stroke, or if we have a parent or sibling to have a lipoprotein A elevation. The Europeans in 2019 said that lipoprotein should be considered for each single adult person's lifetime to identify those at very high levels of lipoprotein A, which is over 180 milligrams per deciliter, which might have a lifetime risk of atherosclerosis equivalent to those with familial hypercholesterolemia. So look at the European guidelines. They even pushed it to having a screening test for lipoprotein A measurement for every single individual. And it should be considered in selected patients with a family history of premature cardiovascular disease or people who are borderline moderate risk, and we want to really enhance, again, a risk enhancer with the elevated lipoprotein A. And just a recommendation for clinical screening premature cardiovascular disease, it makes sense to at least measure lipoprotein at once. Intermediate cardiovascular risk group to enhance is the patient at really the moderate risk, or actually he or she is high risk. Recurrent vascular disease, again, a recurrent vascular disease, it's not just the LDL, it's other factors. Familial hypercholesterolemia, genetic defects of hemostasis, homocysteine metabolism because of the prothrombotic effect, and elevated cardiovascular risk. These are the patient groups that should have a lipoprotein A, not only everybody. So we come to the management, and this is quite a controversial entity. There are so many data on interventions to reduce elevated lipoprotein A. There's data with niacin. Statin therapy actually is heterogeneous. Hormone replacement therapy, so estrogen-related hormones especially, can reduce lipoprotein A. PCSK9 inhibition, consistently with evolocumab and alirocumab, have reduced lipoprotein A in the range of 25 to 30%, but the most effective is the dialysis of this, what we call lipoprotein apheresis. And this is probably the most consistent or the most powerful also reduction of lipoprotein A. There are others like the ApoB antisense oligonucleotide mipomersen, which is used in familial hypercholesterolemia. CETP inhibitors, it's a question. They are in development of a program to reduce lipoprotein A, but we don't have really solid data on this right now. Actually, these are not just the only approaches that have been used. Actually, even aspirin has been shown in some studies to decrease lipoprotein A by 20%, and this was a postulation years and years ago that aspirin can prevent cardiovascular events in primary prevention. But again, of course, we know after ASCEND and ARRIVE, aspirin in primary prevention is questionable. Sex hormones, thyroid hormones, but of course, they're clinically not relevant, especially if the patient does not have or does not require a thyroid replacement. L-carnitine, but again, the clinical significance is unknown. Statins, and I have to reiterate here, statins have a variable effect on lipoprotein A. They're not consistent. Niacin is consistent, decrease from 20 to 30%, and lipid apheresis. And if we look just quickly at data, we can see that hormone replacement therapy, estrogen containing especially, does reduce lipoprotein A much more significantly than simvastatin, as you can see on the right-hand side. This is an important thing. But of course, hormone replacement therapy is important for females that require it, not everybody. Niacin, liraglutide combination has been shown to reduce a significant reduction of lipoprotein concentration in the range of 15 to 20%. And it's one of the commonly used, but of course, we know the niacin does have its side effects and have its problems. And this study, the HPS2 Thrive, has shown its effect, but again, questionable to use niacin. Consistent reduction with evolocumab across the doses, and as you increase the dose, this makes a lot of sense. There is an increase in the lipoprotein A reduction. So and so also with alirocumab, as you can see, again, up to 27% reduction. But the apheresis, as you can see from these different studies, is the most consistent with lipoprotein reduction in the minimum of 50%, in the maximum of 64%. But what are the outcomes? They're questionable. Some outcomes were with reduction of MACE. Some outcomes did not show an event rate differentiation. Some showed improvement, a little bit of regression in angiographic changes. But of course, all of these are small studies that do not really change the guidelines or the way we have to manage people with LDL apheresis. But this study published in 2009 showed that reduction of LDL lipoprotein A through apheresis showed a reduction in MACE rate, PCI rate, CABG rate, and MI rate. And of course, the percentages are so big, but again, it was not very well controlled. The number of patients were not so big, so we cannot really say that this is the only medication or the only way to lower elevated lipoprotein A. But what are the targets? Questionable. Again, we started off to say that the way of measurement has not been standardized between the WHO and other different health initiators. But the desirable is below 14. A borderline risk is 14 to 30 milligrams per deciliter. Anything above 30 starts the risk really to become high, and above 50 is quite high. And these are the numbers most entities and bodies really agree upon. Let's put it in an algorithm so it will be a little bit easier. Let's say the lipoprotein of your patient, lipoprotein A, of course, of your patient is 30 or above. If the patient is in primary prevention with no atherosclerosis, what you should do is optimize all the other residual factors, including LDL cholesterol, control the blood pressure, control the blood sugar, makes a lot of sense. But if the patient has atherosclerosis or is at very high risk and the patient's risk factors have been optimized, whether therapy or not, and of course here consideration of PCSK9 inhibition is quite important because it does also reduce lipoprotein A on top, and there's progression of atherosclerosis on top of the optimization of all risk factors, then we can consider at the end result apheresis if the lipoprotein A is above 60. Because it's a costly procedure, because it is not available to all, because it is not easily found in most centers around the world. So the take-home message, as we saw, lipoprotein A is not just some old thing. It is one of the important lipoproteins, and it is an indicator of cardiovascular disease. It's pro-atherogenic, it's pro-inflammatory, it's pro-thrombotic. And whether or not patients with elevated lipoprotein A needed to be treated, this is according to the risk of the patient. We've seen the guidelines, the American and European, they look at those who are at risk, like familial hypercholesterolemia, those with a positive family history in first-degree relatives, or those with recurrent events that are very high risk and are controlled but are still getting the events. It could be lipoprotein A. After, of course, we look at ApoB or non-HDL, like Professor Ashraf said. How to manage lipoprotein A? Actually, you treat the patient's overall risk. That's the most important. But the medications that have shown reduction of lipoprotein A have been niacin, and again, a medication not really preferred anymore by us cardiologists because because statins do decrease the endpoints. PCSK9 inhibitors on top are also medications that have been shown to effectively lower LDL and lipoprotein A, and LDL apheresis as an end result if we are not reaching the targets we have there. So do not forget that there are other risk factors than LDL cholesterol. Lipoprotein A is one of them. And thank you.
شكرا دكتور احمد على this elegant, very elegant lecture. And now, if any question from the panelists.
مساء الخير دكتور تامر. مساء الخير دكتور احمد.
دكتور عاطف, it's a pleasure to have you, sir.
دكتور اشرف بيه موجود؟
ايوه معاك يا عاطف.
ازيك يا ازي حالك بين الناس اللي وراك دول.
فاميليا
دكتور احمد
هايبركوليستريميا ريسيرش فورم.
طبعا دكتور احمد, thank you very much, elegant as always.
Thank you.
For patient with very high risk, the guidelines stated only for Ldl cholesterol, and if something happened and a new event happened, we should estimate Ldl lipoprotein. But I see that the line and the way they make the consensus now, and the all in the ACC, as I watched, and the many programs I see, they're starting now to put lipoprotein A as an essentiality for detection of the category of the risk of the patient, not only for high risk, but to prevent the coming events. Because lipoprotein, we will never know about it if we not measure it. What do you think about this way in thinking?
Very good point, Professor Atif, because actually the European guidelines in 2019, they said that every single adult should have a lipoprotein A assessment, but
Yes.
it has never been alluded to what is the target of therapy here, and it is not being discussed. But of course, it was at the beginning thinking of patients with recurrent events only, but this has been changed over time to patients at borderline risk as a risk enhancer, and also patients with family history. And now, as you really put it in very important words, it should be measured for every adult because it might have a very high risk, like heterozygous familial hypercholesterolemia.
Yes. Thank you.
Thank you.
In the same.
Ahmed.
Okay, Ashraf, go. Proceed.
The relation between lipoprotein and aortic sclerosis, aortic calcification or aortic stenosis. Actually, I don't know what if there is. You read something about the relations, the pathological. What is the reason?
There are some data, just like LDL, that this is not, of course, a lot of patients, but there are an increase of especially calcific aortic stenosis with an increase of LDL cholesterol and lipoprotein A2. I think lipoprotein A, if you want to, describe it, it could be the smaller brother of LDL cholesterol. Why is it difficult? Why is it not so important in the guidelines? Maybe because we don't have a unified way of measuring it. But yes, there is a very important definite correlation between lipoprotein A, LDL with degenerative calcific aortic stenosis.
So I think if we have a guy with aortic stenosis non-explained at young age, I think we should put in mind lipoprotein little a as a possible cause, especially if he has some other subclinical atherosclerosis.
Yeah, I agree, and it's only written in the American guidelines, this part, as a class 2B, but it should be really put in consideration. Yes, I agree totally, Professor Ashraf.
Ahmed, what's the comment about Professor that commented on lipoprotein A? He considered it as the deadly cholesterol. What's your
as the what, sir?
Lipoprotein E is the deadly. Yes,
I agree totally. I think lipoprotein A is as bad as LDL. We didn't have a lot of data on lipoprotein A because it's like 30, 40 years younger than LDL cholesterol. But the problem of LDL, lipoprotein A, even LDL had the problem, and Professor Ashraf put it very nicely. We do not know. Do we count the particles or count the cholesterol content, which is more atherogenic? In lipoprotein A, we have more than 200, 300 isoforms because of the Kringle 4 repetition, isoforms. So actually, there is no standardized way of lipoprotein A that is 100% specific, but we're getting there. But I agree totally. It's a deadly thing. And if you look at the indications, it's the same indications of LDL and the same prospects that LDL does for the patient.
Actually, I came through a paper about the Indian population and the premature atherosclerosis. A lot of this population in South Asia having extensive diffuse atherosclerosis at young age. And many of them have not much elevated LDL cholesterol and total cholesterol. And this paper showed that the premature atherosclerosis guy in Indian and South Asian, many of them have these problems of genetic problems, LDL little a. And unfortunately, LDL little a elevation is a genetic disease. It does not affected by lifestyle intervention or by statin. And this is the problem. So if you have a premature atherosclerosis with no evidence of heterozygous familial hypercholesterolemia and the elevated total cholesterol and LDL cholesterol, this is another situation in which you should look at the lipoprotein little a.
Definitely. But the most consistent data actually, they show that the highest risk group is the Africans, followed, as you said, by the Asiatic people, yes.
Yeah. Okay, so if there is no other questions from my...
Dr. Ahmed.
Yes, sir.
بعد إذنك دكتور أشرف. In the pipelines now for the genetic biotech or biotechnology, we find now many investigators do some investigating drugs for the lipoprotein A. Do you think it will make a shift in our practice and in our standing to prevent the atherosclerosis from the beginning of the early life?
A lovely question. I always look to things in a practical way, and I really thank Professor Ashraf for giving this, looking from the clinical perspective. Statins definitely reduce inflammation, reduce LDL, and they reduce mortality. What if we find a patient with an elevated lipoprotein A? Probability that we are going to be more aggressive using PCSK9 modulation, whether monoclonal antibodies or inclisiran with the small interfering RNA, I think this could be the next probability of managing of lipoprotein A elevations.
Thank you, Doctor.
Thank you.
Okay, I think we come to the end of this part one of the lipidology course. I would like to thank you all, my dear colleagues and the professors. It was a nice evening with rich in knowledge. Thank you, Professor Shawqi, for preparing this important subject. Dr. Salim, Dr. Tamer, Dr. Atf al-Bahari, Dr. Hani Ragi, Professor Mohammed al-Namani. And thank you, Novartis, for endorsing the CME activity of IAVA. Thank you, ICOM, for their technical support, and see you in the coming parts of this essential of clinical lipidology course. Thank you all. Bye.
Thank you very much.
Bye.
Thank you very much.